Hello everyone, this is Maureen Dobbins from Health Evidence talking to you today about child and family health program planning, and we have 4 reviews that we're going to talk to you today. I guess I'm just looking at the results of the poll in terms of where everyone is from, and so for many of us it's good afternoon. It looks like a good evening for our guest from Europe, and good morning to a few people on the western side of Canada. So welcome everyone. We're really glad to have you all here today to learn about the results of 4 reviews that relate in varying ways to child and family health in public health. This is the first, our first webinar of 2012. This is following some webinars that were held in the latter part of 2011, and we're very excited to be able to continue offering these webinars throughout 2012. This is just a quick picture of the team for those of you who don't know our faces, and actually everyone is helping out today. So those of you who have been involved in hosting webinars before know that it takes a full team to provide all of the mechanics, and so everyone will be online and also providing support in terms of questions that you might have. So just wanted to tell you a little bit about health evidence. And so I actually am seeing from the poll there that a great majority of you have heard of health evidence, and that's excellent to hear. Just briefly, for those of you for whom health evidence is a new resource, health evidence is an online registry that can be used by primarily public health decision makers, as well as students and other researchers, and we're learning even other healthcare professionals in other fields are also finding health evidence useful. But basically, it's we're just trying to promote easier access to the best available evidence to answer questions about what works in public health. We first started developing health evidence many years ago now, and went across the country asking frontline decision makers what they needed and wanted in a resource such as health evidence, and we've attempted to create a resource that listened to and responded to the needs and preferences expressed at that time. We're also always happy to hear your ideas and thoughts about how to improve health evidence. On the actual site, there is a contact us link that I would encourage you to connect with us. Then you could provide us with your feedback and suggestions. And health evidence houses exclusively systematic reviews evaluating the effectiveness of public health interventions using a fairly broad definition of public health, but taken primarily from scanning how public health services are provided in all provinces and territories in the country. We're hoping that health evidence saves you time and that it's bypassing the need to go to the large databases that are out there. It's a smaller database that only has relevant information to public health, so again will save you time in terms of those number of hits you're getting back from a search will be smaller than if you were to go to Medline and search there. We try to be very transparent in how we proceed from running our searches to deciding what reviews make it into health evidence, to how we assess each review for evidence, and how we write our summaries about those. So everything is there for you to download our tools and take a look at them. We also know that access to the evidence is only one part of a bigger, more comprehensive knowledge translation process. And with that, we also offer a variety of other services to develop knowledge, skill, and capacity for for integrating the best available evidence into routine practice and decision making. So today's webinar has been made possible through a CIHR funded grant, which is called the Meetings Planning and Dissemination Project. And in that grant, we proposed to bring the evidence to the front line of public health of reviews that actually had been funded by CIHR. And actually we were very happy in our search for CIHR-funded public health relevant reviews to have identified a fair number of those that are going on in Canada. So it's wonderful to be able to see so much public health work being conducted at the review level and being funded by CIHR. So we also recognize today that we are covering many different areas. These 4 reviews go from calcium supplementation for improving bone mineral density to 2 internet-based interventions. One's for the prevention of eating disorders, and one is for self-management interventions for youth with health conditions. And then the third one is an alternative to inpatient mental health care for children and young people. So we understand that that's a wide variety of topics, and that some of you might be here to only hear the results of 1 or maybe 2 of those. So we would anticipate some people leaving the call throughout the webinar, and certainly that is fine with us. If you can stay for the whole time, that would be wonderful. But with that, I just wanted to say at this point, in case anyone does need to leave early, that we are evaluating these webinars, and so please take note that following the webinar, we will be providing you, sending you a link to a survey. I promise it is a short one. It is only 5 minutes, but very, very important for us in terms of getting your feedback on how the webinars are going, and we're very much wanting to hear your feedback and to make changes as you indicate to us. So if you need to leave early, just so that you know that this will be happening, and you will be, we have the email address of the person whose name will be sending those surveys to you. So I just thought I'd take a moment there to see if there's any questions that everyone has. Make sure you're all hearing me okay. And it sounds like everything is going okay, so we're just going to jump right into why we're all here. So the first summary that we're going to talk is by Weisenberg. It was published in 2006. And we can see here that it's, as I've indicated earlier, it's calcium supplementation for improving bone mineral density in children, evidence and implications for public health. And what you can actually see, we're just going to put the cursor on it right now, is so where you see the little pencil sign is if you were to cite. So we're telling you what the citation is for this particular review, and where you would also, from the summary statement, know where to go to find that if you were just looking at the summary statement. So just before I start talking about our PICO, what was this review about? I think we've posted another question there around who's heard of PICO, and similar here, number of people, looks like we're a bit more than half are saying they have heard of PICO. A few people haven't. So just quickly, PICO provides us with a template for really clearly articulating who the population is that we're interested in knowing something about, what intervention or interventions we are interested in learning about the effectiveness of. And when I say intervention, it could be broader than that. We could be evaluating a policy, we could be evaluating a program, we could be evaluating a very specific intervention or a specific activity within an intervention. So it's for whoever is asking the question, this is a call for them to be really thinking very clearly about what they are looking for there. You may be interested in knowing what the intervention is being compared to. So this could be no care, no program. It could be what might be considered standard care, or it could be an alternative intervention. So for example, if we were thinking about 2 drugs, you could be comparing 2 drugs or no drugs, and in the public health we could be comparing a school-based physical activity program to there being no school-based physical activity program. And then finally in our PICO, our O identifies for us what outcome or outcomes we really want to know about. And this is very important to be articulating in two places. If you were to search the evidence, search databases for information on a particular practice-based issue you have, you would really want to know what those outcomes are. Or if you know you have an issue, we would like that to be very clearly articulated in the summaries, in the reviews that we're finding in the evidence, so that we can tell very quickly if the right population intervention and outcomes are being discussed in that review. So here today we see that this review by Weisenberg includes healthy children that are younger than 18 years of age. They are looking at a variety of ways in which calcium supplementation is occurring, and they also provide a range in there of the amount of calcium. This is being compared to placebo. So it's a drug. It's made to look like a drug that wouldn't have anything in it, any medicinal purposes in it. And then our outcome is bone mineral density or bone mineral content of these four specific places: the hip, spine, arm, and then the body overall. So just moving into our overall conclusions about what this evidence is telling us today. So by and large, what we learned from this review is that calcium supplementation had a small positive effect on bone mineral density just for the upper limb, and that this was observed in the short term, but wasn't something that was seen long term. So once the children stopped taking the calcium supplementation, then that increase in bone mineral density in the upper limb was no longer observed. We also, the other major finding was that there was no impact on bone mineral content for the body overall, femoral neck, or lumbar spine. The next key finding was that baseline calcium intake, gender, physical activity, duration of the supplementation, and the type of supplementation, for example, was it by a milk extract or was it some other form of supplementation, none of these factors had an impact on the bone mineral density or bone mineral content. Interestingly, of the studies included in this review, the association between that increase in the upper limb bone mineral density and actual fracture risk, or the number of fractures or proportion of fractures happening, wasn't directly measured and included in these studies. So we'll talk a little bit more about that when we get into some of the very specific findings of this review. And then we're just wanting to make a point here that there are slightly different results presented in this review, and that the ones we have chosen to focus on in this summary statement are those taken from the sensitivity analysis. It is our opinion that the sensitivity analysis is a more conservative estimate of effect. It slightly changed the results a little bit to make them more conservative, and we felt that that's a more appropriate set of analyses to highlight here for you. So that's what the actual conclusions and findings of the review were. And when we think about, well, what are the implications now for public health practice? So this review suggests that there are no gains to be made from promoting calcium supplementation among healthy children. And furthermore, public health decision makers should note that fracture rates were not directly assessed, so that is important. However, based on the small increase in upper limb and the fact that it was not maintained in the long term without ongoing supplementation, means that it's unlikely that the small increase in the upper limb density would actually lead to a significant decrease in fracture risk later in life. And that furthermore, the evidence remains insufficient at this point to make conclusions specific to peripubertal and non-Caucasian populations, or those with a baseline calcium intake below 500 milligrams a day. So there are some populations for which this evidence really doesn't apply, and so we really can't say at this point what impact this would have on those populations. So let's just look a little bit more closely at what the specific evidence was in this review that allowed us to make those overall conclusions and implication statements. So when we look at the first overall finding about what impact calcium supplementation had, we can actually see here that small increase in the upper limb bone mineral density. Compared to placebo, the standard mean difference was 0.14, with our confidence interval there ranging from 0.04 to 0.24. So the good news here is we can see, because our confidence interval does not cross 0, which would be the important number to think about here because of the way our outcome is measured, that we do have a statistically significant finding. So for the upper limb, there was a statistically significant increase in the mineral density. However, what we need to think about is that a big enough impact? How important is that statistically significant finding? And what the authors of this review tell us is that this increase in density would be equal to about a 1.7% greater increase in that density compared to in the supplemented group to those that don't receive the supplement. And that this would translate, this is a hypothesized, extrapolated calculation here where this would translate into a reduced risk of fracture in children between 0.1 and 0.2% per annum. So the interesting thing that they did in this review is they didn't actually observe, that's not the review, in the primary studies in this review, they did not do an assessment that looked at calcium supplementation, let's see if it changes bone mineral density, and let's see if there's a change in the number of fractures happening in children. What they did was they used some other research evidence to identify the average number of fractures or proportion of fractures happening in the population. From there, they identified what the average risk of boys and girls are around fractures, and then from there identified if we increase the upper limb bone density by a small amount, what would we expect to see in a decrease in the fracture risk. So we can see here that it really is a very small reduction in bone fracture risk. And the other thing to point out here as well, as I just alluded to previously, is that when the supplementation stopped, then the actual density decreased in the upper limb. Okay, so there was just another poll question there that said, are you familiar with interpreting forest plots? And so we have here a number of you indicating, we have a number of you here indicating that no, you're not, and so don't worry, we're going to go over that for a moment. And just before we leave this section here, I just wanted to just reiterate again, this particular example is a very good example of how, and we get this many times in public health, where we do have a statistically significant finding, meaning, for example, if we had a p-value here, it would be less than 0.05, but that the other part of the story is thinking about, well, how big is that impact, and then is that impact for lack of a better term, clinically meaningful? Is it important enough that one might act even though you found a statistically significant finding? So let's now take a look at a forest plot. So let me walk you through this a little bit. And for those of you that know me, you would know that I love looking at forest plots. And it's probably a flaw of mine. But what we have here, if we look down the left-hand side, we see here all of the studies that were identified. So there are, I think, about 7 or 8 studies that were included. And a forest plot, we get a forest plot when we conduct a meta-analysis. So a meta-analysis is simply follows all the same procedures that one would follow for doing a systematic review in terms of how we choose our studies, how we decide if they're going to go in or not, how we search for them, how we appraise them for quality, their methodological quality, what data we pull out, how we actually amalgamate it all. And the meta-analysis part actually ends up allowing us to create this little diamond that we're pointing at right here. It's the statistical computation of the results of each of those individual studies to come up with an overall effect. So just going back here a little bit down the far left, we have our studies in the year they've been published. The N column, which gives us numbers here, provides us with the total number of participants in each of those studies. So we can see here very quickly that by and large, these are all of these are relatively small studies. We can easily tell which one is the largest study. It has 114 people. The third one there. It also allows us to quickly identify the smallest studies. The next two columns tell us, oh, and now I see I've actually misinterpreted that myself. So our first N is the number of participants that received the treatment, that were in the treatment group. And the next N and control columns are giving us the number that were in the control group. So that's just giving us basically our background information that allows us to do our calculations. Now straight down through the middle, we see our standard mean difference, and we then have this 95% CI, so that's our 95% confidence interval. So as you look down the line here, you see for each study a black dot and a line. And what we're being given there is the actual answer or effect that was found for that study. And the line is the confidence interval. So where the line ends would be the upper and lower limit of the confidence interval. So one of the things that's really important to look at here, and what forest plots give us, is it gives us a very quick overall chance to see what the results of all of these studies are. And what's interesting to note is that all but one of them cross that line of 0. So Dive is just drawing that for you right now. And that is what is very, very important to understand here. When we're talking about an outcome that one measures like as an average or a mean, then the point at which there's no difference between the intervention group or the control group is equal to 0. So you can see here with me that all but the DIBA study crosses the line of no effect. So by and large, if you had to summarize this in a sentence, you would say, of the however many studies we have here, all but one of them did not have a statistically significant difference in the children that received supplementation versus those that didn't. And we have one that actually does show a nice effect there. We see that in terms of that DIBA study. Now the next column over is called weight. And then we have numbers there. We have, I think that's a 7.0, 3.1, 15. So these are percentages. And what this tells us here is what percentage of influence or how much weight each study contributed to that overall diamond. So if we take a quick moment here to take a look at this, we see that the, looks like, and the writing here, I think I really do need to buy my reading glasses now. Makovic, it's really small writing. Makovic contributes the largest amount of weight to the overall finding, but that's followed closely. Sorry, I've misread that. We have Chevely has 15%, and then we have the one at 11.2, and then we have a few at around 10%. So what this allows you to do, it allows you to see very quickly which studies are contributing the most influence, which are contributing the least. And normally what you're going to see is those studies that tended to be the larger studies are the ones that will contribute the greatest weight to the overall finding. And then in our final column here, we actually get the answer of each study that was put into the calculation, as well as its coinciding 95% confidence interval. And so again, here we see all of these results, and in the very last one there, that again is giving you the actual number with the diamond. So that's what the diamond represents there. And we can see here, I guess if we blew this up even bigger, you would see that that diamond is not actually touching the line of no effect, but that it's actually not that far off the line of no effect. Okay, so just a quick one-on-one there on interpreting forest plots. But now if we just move on into what were some of the other results of this review, we did see that there was no impact observed on all of the other areas of the body for either bone mineral density or bone mineral content. So what are those implications then for policy and practice in public health? The calcium supplementation among healthy children by public health is not supported at this time. And again, this is really important when we think about what does evidence-informed decision-making mean in public health. And knowing that new evidence is being generated all of the time. And so with the best available evidence at this point, this is the direction, or this is the finding that would be supported at this point. But we need to likely be continue to revisit this as new evidence becomes available. And then the other implication to think about is that there is insufficient evidence right now to support calcium supplementation of any dose or duration among healthy children to increase long-term lumbar bone mineral content, so all the other areas of the body. So we have insufficient evidence at this point, which I know isn't always the most helpful thing for decision makers to hear. And so it might be that's when it's really important to think about what are all the other sources of information that decision makers can turn to help inform decisions, until at which time there is better and more sufficient evidence to answer that question. So again, just as a recap, calcium supplementation did have a small and positive effect for the upper limb, but that is not maintained in the long term. It's not impacting any other parts of the body. That the impact of supplementation doesn't appear to be impacted by gender or the way in which you take the supplementation or the amount of physical activity, and that at this point there is a need to do more research thinking about, well, what impact does this actually have on fracture risk and or actual fractures. And then finally, in terms of those implications for public health, that it is likely not warranted at this point based on the findings presented in this review. So just take a breather there for a moment to see if there are any questions or comments that you have about the findings from Weisenberg 2006. So it doesn't look like I'm seeing anything being raised right now as questions. So certainly as well, I forgot to mention this at the beginning, but we will be holding a discussion forum, an online discussion forum, and would invite you, if you do have comments or questions, examples of any of the reviews we're discussing today that you would like to bring to that discussion forum, we would be happy to help facilitate ongoing discussion and answer additional questions. Okay, so let's move on now. In the next review, we're going to talk about is internet-based innovations for the prevention of eating disorders, evidence and implications for public health. And this is based on a review by Newton and Saliska conducted in 2006. Our PICO is general public. Our intervention were internet-based programs that used a variety of formats, guided or non-guided, synchronous, meaning real-time chat rooms, or asynchronous, and or individual or group program. This was, the comparison group were on a waiting list, And the primary outcomes are disordered eating behavior outcomes and body mass index and body satisfaction. And then there were also a few additional secondary outcomes. One thing I failed to mention in the first review, and which Diva has highlighted here, is the quality of this review. So for every review on health evidence staff assess the methodological quality of those reviews, and we provide that assessment there for you. We use a rating scale out of 10 criteria. And as we can see here, this review received a rating of 10 out of 10, so you can't get any stronger than that. And if you were on the site, you could click on the link there where it says here, and that would take you to our actual tool where the assessment has been filled in, and you could see, in this case, you're just going to see 10 yeses, but in other reviews that would be useful. If we had indicated there was a limitation of that review, you could go in and see what those limitations were. So this is a very well done review based on a small number of weak quality studies. And we felt it was important to point that out to you, that there is a difference between the quality of a review, and you can have a very high quality, methodologically rigorous review being done, systematic review or meta-analysis, but that the studies upon which that review is based might not be very strong or rigorous evidence, and that's the case that we have here. And so the concern that we just need to have, not with the review but with these findings, is that as quality rigor goes down in our studies, we might feel less confident in how we might actually apply those. So it's just keeping that in the back of your mind as you go through these results. So generally what the findings of this review were is that interventions consisting of psychoeducational readings and reflections, internet-based body image journaling, and asynchronous internet discussion groups resulted in perceptions of increased support and improved knowledge, but that these interventions had no impact on body satisfaction, eating disordered attitudes, and behaviors. It's also important to point out that declining completion rates were associated with discomfort with the intervention, so something about perhaps the internet or online. The lack of face-to-face contact was also identified as being associated with the declining completion rates, and then concerns with privacy / confidentiality. So what are our overall implications for policy and practice? Is that eating disorder prevention programs should use or encourage internet-based programs and online discussion boards to improve healthy lifestyles, attitudes, behaviors, and knowledge. These programs are not as effective for improving disordered eating and symptomatology. Public health should expect internet-based eating disorder programs to generate high satisfaction, but should also be cautious given programs can create some discomfort as personal information is disclosed and face-to-face contact is eliminated. So therefore, strategies to minimize these anxieties and frustrations might need to also be thought about and implemented. And then finally, as I started out, given that this overall evidence, the quality of this evidence at this point is weak, we need to be careful in how we interpret and use that evidence in program planning. So when we delve down a little bit deeper into what the actual findings were in relation to body satisfaction, attitudes, and behaviors, we know that this evidence came from 5 randomized controlled trials representing 356 participants. And overall, the findings from those 5 trials indicated that there was no impact on restraint, eating concern, shape concern, weight concern, or eating disordered attitudes and behaviors, body satisfaction, or eating attitudes. And so the implication being that based on this evidence, internet-based public health programs for achieving these outcomes is not supported at this time. In terms of social support, which was an internet-based discussion groups and came from 2 randomized controlled trials, the evidence illustrated that participants in the program reported a moderate amount of support as well as self and other acceptance from the online discussion boards. And so the implication for practice and policy being a strategy to improve perceived social support among this population, public health might want to consider implementing discussion groups. And then with respect to knowledge and the results from 1 randomized controlled trial and 1 quasi-experimental group, and what we mean by that would be there are 2 groups, 1 group that is receiving an intervention, 1 group that isn't, but they just have not been randomly allocated to receive one or the other. So we found here that, or the reviewers found, statistically significant improvements in knowledge were observed when participants were exposed to a multi-session intervention focused on healthy lifestyle, attitudes, and behaviors. That also allowed time for participants to reflect on new learning and experiment with newly acquired skills. So it's a little bit of the knowledge acquisition as well as practice to try new things out. The implication being public health should consider internet-based eating disorder prevention programs for improving knowledge related to healthy lifestyle and attitudes and behaviors. So it's also important here to evaluate that experience with online mechanisms. And so here they looked at evaluating software experience. It was a qualitative findings from 1 randomized controlled trial and 1 quasi-experimental. And they found that 77.5% of participants reported high satisfaction with the program. Students reported feeling that they could talk about their concerns in the online discussion group and felt supported. Other group members understood their concerns, and the input they received from group members was trusted. However, some participants expressed high levels of anxiety and frustration related to their comments being posted on the internet. So what do we make of these findings? Public health should provide internet-based prevention programs for eating disorders, considering it was viewed as being useful, helpful, and fun. However, this type of program could negatively impact participants. Therefore, public health should consider the potential impact of internet posted messages, that this could have an impact in that they might need to also be doing something again around anxiety or frustration from that. So just to recap again, overall there is some evidence to suggest that psychoeducational readings and reflections and internet-based image journaling, asynchronous internet discussion groups can result in increased perceptions of increased support and improved knowledge, but this isn't necessarily having a positive impact on body satisfaction and eating disordered attitudes and behavior, and that there are a few challenges and issues in terms of discomfort with the intervention, the lack of face-to-face contact, and privacy confidentiality. So it's a bit of a mixed bag here in terms of what to suggest as implications, because depending on what outcome it is you're trying to achieve, you may want to become more engaged in the internet as a strategy for this population, and particularly as it relates to knowledge and feelings of support. There's evidence here to suggest that discussion forums are a way to do that, but it's not necessarily going to impact on disordered eating and symptomatology. So I'm just going to take a moment there to see if there's any questions or comments that you have. So we have a very quiet group today. I hope I'm going to assume that that's a good sign. Certainly let us know if you have any comments. So let's move on now to our third review of the day. It's the second one that involves the internet. So this is by Stinson, published in 2009, Internet-Based Self-Management Interventions for Youth with Health Conditions, Evidence and Implications for Public Health. Our population is children and youth between 6 and 18 years of age who have health conditions. The intervention is an internet-based or enabled self-management education, such as handheld computers, video or telehealth programs, CD-ROMs, video games, being compared to standard care. And our main outcomes are knowledge, social support, self-efficacy, emotions, and health behaviors, and health outcomes. For example, frequency of symptoms, quality of life, and resource utilization. So that could be visits to the ER, visits to primary care physician, that type of healthcare utilization. And we can also see here that this is a strong review. It received a rating of 9, and so there aren't any concerns here in terms of the methodological quality of this review. So overall, internet-based self-management interventions for youth with health conditions improved symptoms among participants, improved disease-specific knowledge as it related to asthma, and also showed that it was cost-effective. However, had mixed effects on healthcare utilization and quality of life. And so what we mean there is that the reviewers found that we would have some studies saying it for example, led to a decrease in healthcare utilization, whereas others would have found that it didn't have any impact, and the same for quality of life. The intervention appeared to be most effective among children with asthma and more effective in certain subpopulations, for example, older children with lower socioeconomic status and African Americans. So what are the overall findings for public health policy and practice? Public health should support internet-based self-management interventions, particularly for older children with low SES and African American youth. 2, 1, increase symptom-free days and medication use and decrease school days missed and activity restrictions. Increase asthma knowledge to result in decreased emergency room visits and physician consults, and to provide cost-effective educational programs to improve health and asthma knowledge. However, the internet-based self-management interventions are not supported. So in terms of if your main goal is to improve overall quality of life or to result in decreased healthcare utilization other than ER visits or physician consultation, then this is likely not the way to go. So when we look a little bit more closely at what the evidence was, when we look at improving health outcomes in terms of symptom management or disease control, this evidence is based on 9 studies that were included in this review. 7 studies found improvements in symptom management or disease control, for example, symptom-free days or the use of medication, the number of school days missed, and activity restrictions. So those who received these interventions, these internet-based interventions, did better on those outcomes in comparison to those in the control. So our implications for public health policy and practice is that public health programs should consider using internet-based self-management education interventions to improve these outcomes here. And I see that there's a question that's been posted by Julie. And Julie, we're just in the process of looking through the documents to address your question, and so we'll get back to you shortly. So for just moving on in terms of disease-related knowledge, this evidence is based on 4 studies, and the evidence tells us that 2 of 3 studies on asthma found an increase in knowledge among the intervention groups compared to control, whereas the fourth study did not, and that there was no impact on improvements in encoparesis studies. So there was one study that looked at that, did not see a significant improvement. So implications for public health practice. Public health programs should use internet-based self-management education to increase asthma knowledge among children. but perhaps for other areas it might not help us get to the outcomes that we're really hoping for. All right, so when we now look at quality of life, we have evidence from 6 studies. Only 2 of 6 studies found improvements in quality of life among those in the intervention group compared to control, and 4 studies did not report outcome data. So our implications at this point, this is a bit of a tricky one here because really this is a very limited amount of evidence, and so one would want to rely on this evidence cautiously, and is likely another indication, another one of those instances where other evidence would likely be very important to consider here. But overall, based on what we know at this point, public health should not rely on internet-based education programs for children with asthma to improve their quality of life. So I'm just trying to read lots of things on the fly here, so let me take a stab at this. So the question, and I'm just going to read it out loud, Julie, so I know what the question is. Was there any anecdotal evidence from the eating disorder participants about what would have worked to change body image or eating disorder behavior? Do the participants have insight into what will help them? And so we're just actually looked at the review, and I'm going to, okay, so the very short answer is no, that it doesn't appear that these studies necessarily looked at that. So again, keeping it in mind, this is a review of multiple studies, and to get an answer to your particular question, which is a very good question, might require actually pulling the individual studies that this review is based upon and looking at those more closely. But what I can read to you from the review is that one study, participants identified the treatment website as one of the well-designed aspects of the program. However, with respect to helpfulness, the therapist's telephone calls were endorsed more frequently than the website. One study measured the participants' attitude toward computers, i.e. enjoyment, satisfaction, and comfort with computers at baseline, which was found to be positively correlated with greater website use for parents in the behavioral group. So I think based on what's been published in this review, there is not an answer to your question, and it is one of the challenges in doing reviews that, you know, the more we synthesize, the less we lose from so one of the things here is that the more we synthesize, then the less detail we get about individual studies. So we just have another question here, and this question is saying, curious if this evidence with 9 studies is better than previous eating disorder evidence that only had 5 trials and yet both quality ratings good. And that's actually an excellent question. So Diva, if you could take us back to the slide that has the 9 studies, that talks about the 9 studies. So there, so improving. So if I have your question right, Fave, and certainly write back in if I've got this wrong, but this particular, if we're referring to these 9 studies here, this is looking at a different group of studies than the 5 that would have been included in the previous review, which I'm thinking you're referring to the Newton review, if I've got that right. And so, okay, thank you. So that's sort of like, that question is sort of like comparing apples and oranges in terms of these studies are trying to answer I do not believe these 9 studies are looking at eating disorders, but other types of health conditions that children have. And I would be surprised that there would be overlap with the 5 trials that were discussed in the eating disorder review. But you do point out a good point in terms of when we think about a hierarchy of evidence that are randomized controlled trials, but well-done randomized controlled trials provide us with the most confidence in an answer, and that they would give us more confidence than designs that aren't that don't randomly allocate to intervention and control. Of course, we need to keep in mind that, particularly in public health, there are many instances in which a randomized control trial is completely not feasible or ethical, and so we then have to, design studies without that and deal with those limitations that go along with not having a randomized control trial. Okay, so the issue being, you said, was to use caution with the evidence, and so what I was so just to recap, there is where we had some of the findings in the previous review, we ended up with only one study or two studies. One was an RCT and one was quasi-experimental. And so, and here we actually have 9 studies. So it's just, again, it's that fine balance of thinking about, well, what is enough evidence to feel comfortable in making a decision? And I guess for me, 9 feels better than 2. And so that's really all I was just trying to get at here. Okay. All right, so Julie, I'm just coming back to your question because I don't think we might not have done a very good job of answering that yet. So, so the question being, whether or not there's been anything, whether those individual studies look to the participants to see what they thought might have been helpful. And so we relook at it again. We still think that based on the report or the review, the published review, that answer is no. That hasn't been included in those reviews. But that again, it's likely to really know the answer. You would need to go back and look at those individual studies, determine whether or not they had been done well, and then see if they had answered that question. But again, a really good example of, as well, sometimes why randomized control trials, not sometimes, probably more often than not, don't give us the whole answer. So just getting, yes or no, this works or doesn't work, isn't usually enough information, and that we then need to know, well, why didn't it work, or what parts of it could have been different. So a very good question. So just moving on here about healthcare resources. So here we have 4 studies that were included in this review that reported on healthcare resource use. And we found that the reviewers found 2 studies on asthma. Participants found decreases in emergency room visits and physician consultation. 1 study observed a decrease in ER visits only, and then a 4th study reported no effect. So again, a little bit of a mixed bag here, but overall, public health programs should use internet-based programs for children with asthma to decrease ER visits and physician consultation, even though there aren't really, at this point, big differences in hospitalizations and other service use. So with respect to cost effectiveness, we had 4 studies here as well, and all 4 studies found the intervention was more cost effective than traditional educational programs. So for example, when taking into account the labor costs, resource utilization, health insurance, and societal costs. So that's actually a very good sign. So the use of the internet to deliver these types of programs and its positive impact on these outcomes is also cost effective. And so at this point, there is evidence to support incorporating internet-based education in program planning for particularly children with asthma, and that these are cost-effective strategies. So again, just as a recap here, so internet-based self-management interventions for youth with health conditions did improve symptoms as well as knowledge, and they are cost-effective. jury's a little bit out still on healthcare utilization and quality of life, and that these children and these interventions were particularly effective among children with asthma, and then certain subpopulations, older children with lower SES and African Americans. And so, as we've been saying here, that it's at this point supported to be using the internet for these types of activities if your main outcome are things like knowledge, fewer ER visits, less days of school missed, symptom-free days, which for many in public health would be important outcomes. So I'll just stop there briefly. I feel like we've been throwing an awful lot at you at a rapid pace, but just take this opportunity now to see if there are any additional questions or comments that we can address. Okay, so let's just move on then. We have one more review to look at, and this is a review by Shepard, published in 2009. The title, Alternatives to Inpatient Mental Health Care for Children and Young People, Evidence and Implications for Public Health. Our population here are children or adolescents 5 to 18 years of age with a serious mental health condition. Our intervention is mental health services providing specialist or outpatient care. It's being compared to mental health services in an inpatient or equivalent setting. And there's a very long list of outcomes here, both primary and secondary, but those key primary outcomes were disease-specific symptoms, general psychological functioning, acceptability, and cost. And we can see here that, again, this is a very good methodologically sound review. It received an 8 out of 10, so still they've done many things right with this review, and there's just a few areas that we had a few concerns, but overall is a high quality review. So just before we jump right into the overall conclusions and then go through this more closely, just try to bear with us. This actually is a very complicated review with a lot of complicated interventions. So I'm going to give you the highlight right now of what we found and what those implications are. And then as we get into each of the interventions that were assessed, we will provide you with the definitions that were included in the review so that it's clear what all the different interventions were that were being evaluated. So overall, the reviewers found that children with non-specific emotional behavioral disorders, so for those children, home-based multi-systemic therapy reduces symptoms such as aggression and hyperactivity as reported by teachers, reduces the number of days spent out of school, and also was associated with reduced self-reported alcohol use. Intensive home treatment or intensive home-based crisis intervention, however, did not improve symptom severity, number of symptoms, and family cohesion. Okay, so I'm just going to stop here for a moment. So I just have another question that's come in. And the question being, I'm just wondering if you can comment on the second and third review and their dates of publication. So you're correct there in saying that that review was published in 2006, which happened before the advent of social networks. You are correct, and also keeping in mind that the primary studies included in that review then would be published before that, and therefore would have been conducted before that. And so you're very right to point that out, that things have changed considerably since, I guess we can imagine many of these studies would have been conducted in the early 2000s up to the mid-2000s, and that things are very, very different now. And so there would definitely be a call for, if there isn't already a review that's been done elsewhere in the world, for this to now be revisited. So again, just keeping in mind the goal, or what we received some funding to do, was to identify reviews that had been conducted in Canada, funded by CIHR, and this was one that we found, and we didn't find one on this topic that was more recent. So thank you for addressing that. So just coming back to the Shepherd review, so we do find that the intensive home treatment or intensive home-based crisis intervention wasn't associated with decreasing symptom severity or the number of symptoms or family cohesion. And then here we actually have a revisiting of eating disorders. So youth with anorexia nervosa, specialist outpatient treatment did not improve the number of post-discharge nights at inpatient facility, outpatient appointments, or day patient contacts. So overall, what sense do we make of these findings? So based on this review, public health programs should include and or support home-based multisystemic therapy for children with non-specific emotional behavioral disorders, but should not necessarily support or include intensive home treatment for children with non-specific behavioral emotional disorders or specialist outpatient services for youth with anorexia nervosa. And then furthermore, public health decision makers should be aware that the interventions presented in this paper come from a very limited amount of evidence, as well as studies made up of very small sample sizes. So similar to at least one of the other reviews, the Newton review, where again we need to be extra cautious here in that our sample sizes are quite small, which can affect our confidence in the study, and that there aren't a lot of studies upon which to base this evidence. And again, there are a very definite, important call for more research that needs to be done in these areas so that we can actually feel more confident. So let's look a little bit at some of the definitions here. So home-based multisystemic therapy, so MST. And what we're providing you here is how the review defined that. So this isn't what we're saying here at Health Evidence. We're just providing for you what was written in the review. So it's defined as therapists provide therapy to the child and the family together in their home. Families are required to participate, and MST services, according to protocol, are available every day of the week, 24 hours a day. MST therapists will continue to work with clients who are hospitalized. MST follows a standard protocol and is a family-centered, ecologically oriented therapy targeting individual, family, peer, and environmental aspects of psychopathology in the community, and includes the development of aftercare plans. Family therapy, behavioral therapy, and cognitive behavioral therapy are used. Comprehensive crisis plans are developed jointly by the therapist and the child psychiatrist and focus on mobilizing the problem-solving skills within the family and the community. So in the first series of results that we report, this is what was being evaluated, the home-based multisystemic therapy. So from this meta-analysis, when they evaluated the impact of home-based multisystemic therapy, we have evidence from 2 randomized controlled trials. And the findings being, in treating psychosis at 4 months, fewer teacher-reported symptoms is what they found. We see here that the standard mean difference is minus 0.52, fewer teacher-related symptoms, and that confidence interval range from minus 0.9 to minus 0.1. So again, here we know that this is a statistically significant finding, meaning if they had p-values, it would be less than 0.05. We also know that there were fewer days spent out of school. So again here, just under minus 0.5, ranging from minus 0.85 to minus 0.09. And then less self-reported alcohol use. And again here, we see minus 0.49, ranging again from minus 0.87 to minus 0.11. A study of low quality reported reduced self-reported minor delinquency. So we again see here the standard mean difference being minus 2.72, ranging from just under 4 to just under 2. Then in another measure labeled the youth risk behavior scores, we also see a statistically significant reduction. And then also the last outcome there, fewer days of hospitalization. So about half a day left versus those who did not receive the treatment had almost 4 days per month of hospitalization versus half a day. So, and then in terms of no impact, because that was a finding in these two trials, there was no impact on symptom severity, caregiver-reported symptoms, marijuana use, arrests, caregiver satisfaction, self-reported total drug use, family adaptability, and cohesion. So with home-based multisystemic therapy, what are our implications for policy and practice? The findings here would suggest that public health decision makers may consider supporting or encouraging MST as opposed to inpatient care for psychosis, given the positive impact on some of the outcomes. However, for many additional outcomes for both the child and the family, positive improvements should not be expected. So it's going into this, if one were in public health to think about implementing or supporting the implementation of MST, you would really need to be thinking about why and for what purpose, and if the outcomes for which there is a positive outcome are the important ones to you, then you would be warranted in using it. If you were really trying to achieve these additional outcomes, then this on its own would not be supported. So now we need to talk about specialist outpatient services. That was the next outcome intervention that was evaluated. And this type of outcome intervention can be provided by a range of healthcare professionals in clinics. It included a motivational interview, cognitive behavioral therapy, parental counseling, dietary therapy, and multimodal feedback on weight management and monitoring. And so for specialist outpatient services, the evidence comes from one trial. So again, very limited amount of evidence, although it's coming from a randomized controlled trial. And what we found here, or what the reviewers found, that there was no impact on the number of post-discharge nights spent at an inpatient facility, outpatient appointments or day patient contacts for youth with anorexia nervosa, receiving cognitive behavioral therapy, motivational interviewing, and parent counseling compared to those who were in inpatient care. So the implications for policy and practice are that public health decision makers should not promote specialist outpatient services over inpatient treatment for youth with anorexia nervosa, while acknowledging evidence is limited to a single study. So again, this will be important to keep monitoring this field and looking for the results of studies as they are published to see if that would actually change the recommendations. Now let's take a look at intensive home treatment. So the definition is that provides children with therapy in their home to solve problems with the way they interact with other people in the home and to improve their psychological symptoms. It uses a problem-solving approach using a child and family-centered approach with importance placed on addressing difficulties with the psychosocial environment and alleviating individual psychiatric symptoms. So the evidence here shows it comes from two trials, and the evidence illustrated a greater proportion of children with emotional behavior disorders lived at home up to 3 years post-intervention. And when you compared those who received the intensive home treatment to those in inpatient care, 72% of them were living at home 3 years post-intervention versus 50% from those in inpatient care. However, no impact on the number of symptoms for children with behavioral or emotional disorders between groups at 2 to 5 years, or overall parent satisfaction compared to inpatient psychiatric admission. So implications: public health decision makers should not promote intensive home treatment as an alternative to inpatient treatment based on the evidence that we have at this point. So intensive home-based crisis intervention defined as home builders' model for crisis intervention. The focus is on the identification of family and individual psychosocial, cultural, community, and welfare needs. Components include relationship building, reframing problems, anger management, communication, setting treatment goals, and cognitive behavioral therapy. The aim is to prevent an out-of-home placement for children at high risk. Short-term out-of-home placement from 3 days is permitted for respite care purposes in some cases. So we have the evidence upon which this is based came from one trial, and what we see in the review is that intensive home-based crisis intervention for emotional and behavioral disorders found small improvements in social competency. So we can see here 0.34, and the confidence interval ranges from 0.67 to 0.01. So again, here we see a statistically significant finding, and this is being compared to case management. Case management led to improved self-concept 6 months post-intervention. However, no impact at 6 months on child behavior or family cohesion was observed. So implications for policy and practice. Public health decision makers should promote intensive home-based crisis intervention to improve social competency in children with emotional behavioral disorders, but should not promote intensive home-based crisis intervention over case management if the aim is to improve self-concept, behavior, and level of family cohesion. So again, just overall, many things going on in this review, but overall we find that home-based multisystemic therapy reduced symptoms of aggression and hyperactivity reported by teachers, reduced the days spent out of school, and reduced self-reported alcohol use. Intensive home treatment or intensive home-based crisis intervention did not improve symptom severity, number of symptoms, or family cohesion. And that among youth with anorexia nervosa, specialist outpatient treatment did not improve the number of post-discharge nights at inpatient facilities or outpatient appointments or day patient contacts. Therefore, at this point, we again need to be careful about how we interpret these, but there is some evidence to support the home-based multisystemic therapy, but not necessarily the intensive home treatment, crisis intervention, or specialist outpatient services. So that comes to the end of the evidence that we have to present for today, and I'll open it up now to any additional comments or questions. And we have 2 polls that we have asked you to look at right now. The first one, and did you find the data in these reviews helpful, and are these findings new to you? And for those of you that are answering, it looks like most of you are saying yes, you found it helpful and they were new to you today. So that's helpful to know that we were able to bring something new to you. And so I see another question here. The question being, what would be better sample sizes that would be better for doing quality research, and should this be part of the funder's request? That's an excellent question, and I hope you're going to like my answer, because the answer is a bit of depends. Should the funders request, I guess there's a couple of questions there. Should funders be specifically indicating what your sample size is? Definitely yes. Should, in the way grants are assessed, should a power calculation, that's what we would call it, should a calculation be done that would demonstrate that the study will be big enough to see differences, significant differences between groups? Definitely, that should always happen. So what does happen a lot, and I think this is what you were alluding to, Faye, is that many times we hear in public health that a study was done, maybe it was a randomized controlled trial, it might have been a quasi-experimental study, and at the end the authors are saying that our study was too small, it was underpowered to actually see a difference between the groups. So what when we do our studies, we need to make sure that we have enough strength, i.e. enough people in the study that are going to experience the outcome, that we would be able to see whether or not a real difference between the intervention or control group exists. And if our study is too small to do that, then at the end of the day, we don't know if the reason why we didn't see the difference is because the intervention really didn't work or because the study just wasn't big enough. So yes, I would completely agree that particularly amongst funders, that would be an expectation in a study that all of that would have been clearly addressed and described in a study. And certainly if you were submitting a grant to the Canadian Institutes of Health Research to evaluate an intervention, that would definitely be expected, and every grant would be assessed for that. I think you might be referring there to other types of funders that might be less, you know, CIHR is our main health funder, and so that would be a basic attribute that they would look for there, but other funders might not. Now, in terms of what would be a better sample size, the reason why that answer is it depends is because it really depends. The size of your sample and how big it needs to be is dependent on what the outcome is that you're looking at, how it gets measured, and how much of a difference you would expect or are hoping your intervention will have. So if you would be expecting to see a fairly large outcome and that you actually can't even really observe the outcome until it's quite big, then you need more power. You need a bigger difference. You need more people in your study that are going to actually experience the outcome. So it really is very dependent on what you're measuring and its spread throughout the population and what change you might expect to see that then would drive your calculation for figuring out how many people you would need to have in your study. So we actually have in statistical textbooks, there would be something called a power calculation, and in that you would pop in your numbers in terms of how many people, what change in the outcome you would be expecting to see, something called standard deviation. So that would be our spread of all the different outcomes you would expect or be hoping to see. And then from there, that would identify how big your sample is. And I mean, to be more technical, you would also specify to what your degree of error you are willing to accept. So, you know, whether you're willing to be wrong 1 time out of 100 or 5 times out of 100, that also drives then how big your sample size would be. So it's many things that come together, and but definitely is something that should happen with any type of a study that's evaluating the effectiveness of an intervention. So thank you for your comments, and I see here if you could get a copy of the slides used in the presentation. And also to let you know that a recording of the webinar will be available on the Health Evidence website in a couple of days, and we would also be posting there these slides as well as all of the results of the polling that we did throughout today's session. And if you need something beyond that in terms of access to the slides, Fiona, perhaps you could be in touch with us individually about that. So just before we start to wrap up here, again, I just wanted to remind you about the discussion forum. And so a big part of what we're trying to do here with these webinars is actually to spark discussion and debate amongst public health decision makers in Canada, across Canada, but even external to Canada, about what these findings really mean, and really hearing from you. What are the implications for policy and practice? So one of the ways that we are evaluating to do that is through online discussion forums. and that is available here at the website, healthevidence.ca/forum. You would need to access that by logging in with your Health Evidence username and password if you aren't already a registered member. But if you aren't, don't worry. It's a very simple, easy process. We just ask a few simple questions. And we invite all of you to join us live on Monday, February 6th at 1 p.m., where you can post questions. We'll be posting some questions and be there to facilitate and spark some additional ongoing discussions. So we hope to see you there. And really, what we're really keenly interested in is if you have any of your own personal or local context and experience in this topic or in our previous topics that you would like to bring to these discussions, that's really what we're trying to achieve here, is to get decision makers speaking to each other, learning from each other about their experiences in using the evidence. As well, if you would if you have those experiences you would like to share, you could also send us your name in the chat window, and we'd like to connect with you further about that to see how we can include you in ongoing discussions. And then finally, again, just the plug for the evaluation, because we are trying to determine whether or not the webinars, number one, are a good use of your time, are they helpful, and we're trying to assess this as a knowledge translation strategy. So really encouraging you to fill out that survey and let us know how we did today and what you'd like to see changed or kept the same for the future. So if there aren't any other final questions or comments, I'd like to take this opportunity to thank all of you for coming today. It's certainly been a pleasure for me and all of the Health Evidence team to have a closer look at this evidence and to discuss it with you today. I really enjoyed your comments and your questions, and I look forward to ongoing discussion with you at the forum. So thank you again, and we'll see you again soon. Bye-bye.